Hi, I'm Lori Smetanka with the National Consumer Voice for Quality Long-Term Care, and welcome to today's episode of Pursuing Quality Long-Term Care. A key component for providing quality care and ensuring quality of life for any resident of a long-term care facility is knowing the person, for example, knowing their likes and dislikes and their life history. This is especially true for a person living with a cognitive impairment such as dementia, where as the disease progresses, their ability to communicate and engage with others can take different forms. We frequently hear about incidences of conflict between residents with dementia and staff or other residents, and too often we see the response to what some consider challenging behaviors to be prescribing an antipsychotic or psychotropic drug to calm the person down. But there are successful practices for knowing the person and providing good care without drugs, and that's what we're going to be talking about today. Our special guest is Dr. Jonathan Evans, a geriatrician, board certified in internal medicine, geriatrics, and hospice and palliative medicine. A longtime medical director and educator, Dr. Evans is a past president of AMDA, the Society for Post-Acute Long-Term Care, and has held numerous faculty positions at the University of Virginia. Dr. Evans is a strong proponent of person-centered care and the importance of relationships in the provision of care. He considers the details of a person's life story as essential as medical history. Dr. Evans is president-elect of the Consumer Voices Governing Board. And welcome, Dr. Evans. We're really glad to have you with us today.
Thank you so much. It's such a pleasure. And I just want to support all the folks that are listening in and tell you what a difference you make in the world. Thank you.
Well, thank you so much. So as we're thinking about the topic for today, we know that more than half of residents in nursing homes and an increasing number in assisted living facilities are living with dementia. So can you talk for just a minute about the diagnosis and the care needs that arise with a person who has dementia or cognitive impairment?
Yeah, so, and of course the vocabulary is a little bit confusing, but when we talk about dementia, what we're talking about is any condition that results in a loss of brain function that's bad enough to interfere with daily activities. In addition, we're talking about a condition that's expected to be permanent and may be fairly stable over time, but is often slowly progressive. Mm-hmm. There are lots of different types or flavors, if you will, of dementia. You hear about Alzheimer's disease and Lewy body dementia and Pick's disease and frontal lobe dementia and any number of others. But really, they're just referring to specific aspects of different conditions that are characterized by this essentially persistent and presumably permanent loss of the ability to use your brain the way that you once did, that is bad enough that it interferes with your ability to do certain things on a day-to-day basis.
Mm-hmm. Gotcha. And so as you think about, the care needs that arise as the brain function changes and the ability to, make different decisions for yourself, or even to, be aware of your surroundings as, cognitive impairment increases, what are some of the care needs that arise for some of the individuals, and how do we think about, approaching care for them?
Sure. And now when we talk about dementia, we're typically talking about conditions that last for years, and they tend, they're sneaky. They can be very insidious and not obvious for quite some time because the problems they cause can be quite subtle, and individuals are able to compensate even without necessarily trying to. But by and large, the kinds of problems that people might encounter if they're living with dementia are some difficulty to comprehend their world or to communicate. So for example, oftentimes people may experience problems with short-term memory. That's a very dominant feature for many folks. It may result in not being aware of one's surroundings, or what day it is or time and so forth. Maybe being confused about relationships, being able to recognize individuals, essentially forgetting who certain people are to some extent, forgetting names and that sort of stuff, which everybody experiences, but is worse in people who have dementia. And so as a consequence of these And when I'm talking about impairments, I'm talking about essentially the loss of ability to do certain things. Okay, each of those impairments can cause problems of one sort or another. For example, if you have a problem with short-term memory and you're cooking something and you step away from the stove, you may forget that you were cooking something and therefore not go back, and that could increase the risk of a fire or something like that. If you similarly, if you get disoriented or have trouble with short-term memory and you're driving, you may get disoriented and not realize where you are, or how to get back to where you were going if you're in an unfamiliar area or something like that. And so people that are living with dementia are going to have more difficulty in unfamiliar circumstances. And I might add that if you think about dementia as some loss of brain power under other circumstances where a person becomes ill for any reason or is taking medications that might affect the brain, then people may experience a sudden decline in brain function, even though their underlying dementia hasn't really changed much, but other things have caused them to decompensate. So as a consequence, people living with dementia may have more difficulty if they get ill or end up in a hospital or some other unfamiliar setting. One of the big concerns for people living with dementia is safety. Because it may be difficult to recognize risky or unsafe situations.
Absolutely. So I know, as we've talked about before, having a person whose dementia is progressing often have difficulty verbally communicating with other people or making their wishes known to other people, particularly verbally. And that often causes some conflict with caregivers who may not understand what the person is trying to tell them. And so we often hear that staff get frustrated with residents with dementia who don't, behave in a certain way, using air quotes. Sometimes they're resisting care or, pushing back or biting or scratching at someone, essentially, almost seems like they're trying to defend themselves against a particular action. And so, what do you say to, people who are experiencing those types of interactions with people with dementia, and how can we best, think about how we approach someone who may not be able to verbally communicate with you and still, try to understand what they're saying to you and to provide good care for that person?
Yeah, that's really an excellent question. First off, just talking about words for a moment, there have been a number of studies over many, many years, as well as studies of well-known individuals, famous writers, for example, presidents and so forth, where they've kind of looked over their writings and speeches and so forth, and they found that over a period of many years, even preceding the diagnosis of dementia, that the vocabulary gets smaller and smaller. So that's kind of an early feature, and if people's vocabulary decreases, then their ability to communicate with words is somewhat diminished. And of course, the opposite, the reverse of that is that if people's vocabulary is diminished, then their ability to comprehend words or communicate or understand other people's communication is often diminished. Think about when you were in school trying to learn a second language, for example, or if you're in a country where the native language is not one that you speak very well. The ability to communicate is quite limited when you don't have as many words at your disposal. And as a consequence, we tend to communicate through behavior. Or think about a young child who's just developing their ability, their vocabulary and their ability to speak with words. Most often the behavior is the primary form of communication. So to your point, the scenarios that you described are each examples of somebody telling somebody something without words. As you mentioned, they might be expressing that they're frightened. And the other thing I would point out that all of those situations or all of those behaviors that you're describing really represent someone who's living with dementia perceiving or perhaps misperceiving a threat and responding in really kind of a reflexive way, the way any of us would if we were feeling threatened for some reason. Okay, as an example, if you were asleep in your own bed and someone turned the lights on and started touching you or pulling at your clothes, that would be a very threatening situation, and you would automatically respond to protect yourself,
right?
Possibly even by hitting out or something like that. That's just a reflex. You don't even, not only do you not have to think about it, you don't even have time to think about it. And so, right. But in a healthcare setting, that's misperceived as resisting care. So a lot of these situations that you described really represent a conflict between the individual living with dementia and their environment, especially the human environment. And it represents a healthcare culture that's really most exemplified by hospitals, but nursing homes were envisioned and created based on a hospital model. And when you consider that most medical and nursing training is hospital-based, the culture of healthcare and care delivery in all settings is based on that culture. And so just a couple aspects of that culture I'll just mention, and then I'll tie it into some of these situations that you described, is that the healthcare culture is really pretty rigid and inflexible, especially in the hospital. Individual patients are expected to comprehend and conform to the environment. You're in the hospital, for example, you're supposed to stay in your bed unless somebody tells you to get up. You're not even supposed to go to the bathroom without pushing a call bell or something like that, which is not normal for folks. In addition to that, you're expected to let people whom you don't know do things to you, like stick needles in your arm and that sort of stuff, which, or even, undress you in some way, or, touch a part of your body that you've been trained your whole life. You shouldn't do that. You shouldn't do it. So in other words, for us as consumers of healthcare to receive healthcare, we have to basically overcome, at least temporarily, our training as human beings and let people do things that we've been taught not to. Okay. But when people are living with dementia, they often can't make that distinction, and they're just relying on what we'll call this overlearned behavior, which is what they've been taught their whole life. And the other thing I would just point out is that, our healthcare system is what I would refer to as, quote, complaint-based, meaning in order for you to get healthcare, you have to ask for what you want. You have to know what you want, okay? And people living with dementia may not know that. They may not remember that, they're not supposed, let's say they had surgery or, broken hip or something. They may not know that they're not supposed to stand on their broken leg, and so they might end up trying to get up and injuring themselves and so forth. Or they may, be unsteady and, have to get up to go to the bathroom, which is a totally normal thing in the middle of the night, perhaps, and yet without remembering to ask somebody for help, okay? The other thing is that if you think about how care is provided in a hospital, especially, I'm using this as an example just because it's sort of the extreme of healthcare, it's mostly about, quote, task performance, people doing certain things to or for somebody, versus what's really needed for people living with dementia, based on what we talked about earlier, is really more ongoing supervision and engagement, okay? So typically, if you were in a hospital, for example, people would come in and out of your room to do things or check on things, but if there wasn't a task to perform, there wouldn't be anybody else in the room with you. And that model of care delivery is the same in nursing homes and other settings as well, including assisted living, where the individuals that the resident or the patient may come in contact with are, they have a job to do for a number of people. They're trying to do it as efficiently as possible. In the COVID era, they're often doing it without a lot of help because there's, this healthcare crisis has resulted in a lot of, care shortages, really. And so you have increasingly stressed caregivers who are, and including family members for that matter, who have things that they need to get done with a limited amount of time. They're often frustrated and in a hurry. And when they enter a room, they express that frustration or hurry without words, okay, by rushing in or so forth. And that in and of itself is perceived as threatening or, or scary. And as a consequence, any of us would react in the same way, which is to feel anxious or threatened and be on our guard and possibly react to things that we consider especially threatening, like people doing unfamiliar things to us. So what I'm trying to say here is that all these behaviors that you just described, and I've got a list of more, they're not planned in advance. They're not a feature of disease per se. They're normal reactions to perceived threats, okay? And they're kind of reflexive behavior. And so, in other words, those behaviors that we're talking about, they're expected. They're, if you will, normal given the circumstances. And what they're reacting to is the behavior of others. And it's those others, caregivers or other healthcare professionals, that are in complete control of the situation, even though they often feel helpless and out of control, because it's their behavior or it's what they're doing that's prompting this reaction. And so in order to prevent these situations, in order to de-escalate them, it requires people to have some awareness of themselves, okay? And really just kind of step back and forget about this artificial world of healthcare and just think about the world that human beings inhabit and how we relate to one another. Moreover, we talked about behavior as communication. Okay,
right.
It's not a disease or anything. It's not something you make go away with a medicine. That doesn't work. But I would point out that most of us rely way more on the nonverbal communication to help us figure out what's going on than the words themselves. And it's been a lifelong lament of mine that unfortunately the words often get in the way of what I'm trying to say. Okay. So and when people have fewer words at their disposal, the words themselves lose precision. And so we attribute a specific meaning to a word that may not be what's intended. And that results in more confusion and more misunderstanding.
And too often, as you and I have talked about before, the misunderstanding or the reactive behavior that the individual gives when they're either when they're not liking the actions being done to them, are often treated in a way where the caregiver or the staff will say, well, we need to calm that person down and give them a drug or something to calm them down. And that's been very problematic historically. And it doesn't really get at treating the need of that person or addressing what it is that they're trying to tell you.
Absolutely. And you make a really important point. I would just emphasize, sort of underscore what you're saying by pointing out that, and I'm talking about the training that doctors and nurses get, and again, the healthcare culture, that if all you have is a hammer, everything looks like a nail, okay? And, doctors are taught to prescribe medicines in response to symptoms. If I were in front of a group of doctors and I played this game where I hollered out a symptom, nausea, for example, people would yell out their preferred drug to treat nausea. That's how medicine is practiced in this country to some extent, and that's often what's expected. And if you walk into a drugstore and there are rows and rows of over-the-counter medicines, you can just simply match up whatever symptom you're having with whatever's for sale. So that's a big part of our culture, but first of all, treating symptoms doesn't treat the underlying problem necessarily that's causing the symptom. And sometimes it actually inadvertently makes it worse. Any medicine that might be used to try to treat, quote, behavior, in order for that medicine to work in any way, shape, or form, is going to have to affect the brain. And if you give somebody a medicine to affect the brain, and let's be clear, we're talking about slowing down the brain, okay, then it's going to cause other problems with brain function. And as I mentioned at the beginning, people who are living with dementia have a condition that affects their brain, that reduces their, if you will, the reserve capacity of the brain. And when you start adding medicines to that, very often it causes the brain to decompensate in other ways. And so it sometimes makes it often makes the situation worse. But even if it doesn't, it often causes other problems or risk of other problems, including death. Okay. And I might also add that, if there was a medicine out there that worked to make a person not react in a reflexive way to situations, that would, in order for that to be effective, by and large, you would have to suppress the brain function pretty severely in such a way that you could expect that people are going to have other consequences, most often sedation and lethargy and more confusion and so forth. And if the problem, if you will, is caused by confusion and you make somebody more confused, you've just made the problem worse. Okay. But when I hear about, and I hear about this all the time, people calling and asking me for a medicine and so forth, what I hear is somebody who's frustrated, okay, who doesn't know what to do, who feels powerless. And so the way that I respond to that is by helping people understand the situation, trying to figure out what folks are reacting to, my patients, and also what are they trying to tell us with their behavior, and trying to help caregivers take a broader view of the situation. And oftentimes it's such an emotionally charged situation when people are feeling frustrated that sometimes it's just a matter of stepping away for a few minutes. Because people who live with dementia often have problems with short-term memory, they very quickly often forget what it was that caused them to be feeling threatened. And so if people just step away for even a few moments, that's often all that's needed to kind of start over with a fresh start and with no hard feelings. But there's also a misunderstanding among many healthcare professionals, even if they understand that someone has a listed diagnosis. In the heat of the moment, it's hard for people to comprehend that, this person can't help it. This is just a reflexive behavior. And particularly with adults, that's difficult. With children who exhibit the exact same behaviors, the same caregivers often have a very different response because they see the behaviors as normal and typical for a young child under the circumstances. And they might say, well, they're tired or whatever, they can understand and they can forgive and they can move on rather than persisting and trying to do something in spite of that person. So for example, whenever I hear about a phrase like resisting care, to me, I think about that in terms of abuse. Okay, I think here's somebody who's trying to overpower somebody, and those situations cause me a great deal of personal distress because that should never happen. Okay, what that patient is saying is stop. Okay, and that's what the message that I want people I work with to understand.
So as we think about, so for the caregiver who, as you're saying, is, being, is presented with, these different reactions and different behaviors, what I heard you say was oftentimes they need to think about not only their own approach to how they are presenting to that person or how they're approaching the individual themselves, but also, think about the reaction that they're having and don't, keep pushing forward and trying to overpower them, but, take a step back. So it's really kind of rethinking, how they're starting to approach that person to provide whatever care or service or task it is that they're supposed to be providing. And actually, I think about my grandmother had dementia and lived in a long-term care facility. And I remember being with her one day and an aide came in to help brush her teeth. And she approached her with one of those pink-tipped swabby things, that she was going to, try to clean her mouth out. And she went at her and she just kind of shoved that, in her mouth and started really aggressively moving it around. And of course, my grandmother just started, again, pushing back at her and resisting. And, we had to say to her, you need to stop, be more gentle when you're approaching and when you're coming to her to provide that care to her. But that, that seemed, like a perfect example of what you're talking about here, where, the approach impacts the reaction that you're going to get.
Absolutely. That's a great example. And I want to talk about that specific example a little more if you'll indulge me. But just let me just back up a second and say the way that these caregivers are approaching things is, generally speaking, the way they've been taught. Although we've been taught to, in healthcare, we've been taught to do things that are often the opposite of what we've been taught to do as, earlier in our lives by the people, by our teachers and the other people that we love. And most everything that a person needs to know about caring for somebody with dementia, they have within them, and it's how they were taught to live. But I understand all too well how frustrating it is when you are trying to get a task done and the person you're trying to help is not letting you. I mean, my grandmother lived with dementia for many years. She wouldn't let anybody trim her toenails, and I would come visit her and try to trim her nails, and sometimes I could only trim one. Sometimes I could trim one and she would tell me that was enough, and then sometime later I would trim another one. But it could potentially take an hour to trim her toenails, which, from a practical standpoint, isn't going to happen in most healthcare settings. Now, the example you gave of your grandmother is a perfect one, because you think about it. Somebody's coming at her with an object, and there's other changes with vision that people with dementia often experience. They get sort of like a tunnel vision, but basically someone is trying to shove something in her mouth, and that appears threatening. She doesn't know what it is. It's coming at her faster than she can process. The irony of that situation is, and I'm willing to bet, that there was nothing wrong with your grandmother's arms or her ability to use her arms. Okay,
that's right.
And so there's no reason why she couldn't have held it herself. Okay, and a specific example of how you might help somebody brush their teeth or brush their hair if they're living with dementia is to put it in their hand, tell them what it is, break things down step by step, have them try, guide their arm. That's much less threatening than sticking something in their mouth. Imagine that if I was going to try to brush a patient's hair, I'm standing, they're sitting, I'm standing over them with an object in my hand, I'm raising it over their head. They might perceive that I'm about to hit them or something like that. But if I simply put that in their hand, maybe had them touch it with the other hand so they could understand what it was, and then help them to stroke their hair a few times, then that's often all they need to kind of get things going. Now, there is without getting too technical here, one of the problems with dementia is a loss of so-called executive brain function, where one part of the brain, which is supposed to tell other parts of the brain what to do, doesn't work very well. And so people often have difficulty performing tasks for themselves that require multiple steps. So for example, brushing your teeth. Well, you have to take a toothbrush, put some toothpaste on it. You have to pick up the toothbrush with your hand. You have to pick up the toothpaste, put the toothpaste on the toothbrush, move that object, move the toothbrush to your mouth, and then you need to move it in certain ways. And all those things, the more steps there are in a process, the more opportunities there are for things to sort of break down. But if you try to help people by doing things step by step or explaining what you're doing, it helps individuals do things for themselves with some lesser degree of assistance, and it helps them feel more capable. And it also shows caregivers, hey, this is still a functioning human being, and there's value and meaning in doing things for yourself. Okay. So, but again, in our haste and, in our sort of laser focus on getting the job done, we are often unaware of or lose sight of all these other things that are going on,
Yeah, and I think that's really important, and so certainly the way you approach the person and observing their reactions and thinking through a different approach to being more gentle and again, empowering them as much as you can definitely are important aspects. Can we talk also for a minute in terms of like understanding communication and behavior and what the person is trying to tell you for situations that we often hear about where maybe a person is wandering in other people's rooms, or
Sure.
Reacting maybe in some other different way, where it's almost like they're looking for something, or they're having some other reaction or behavior that it might be, again, air quoting, bothersome to
Sure.
other residents around them or other staff. And again, that often causes a misunderstanding with what they're trying to communicate to people if they're not, kind of knowing what that person is trying to say.
Absolutely. And I should mention first that in almost any care setting, or certainly in any nursing home, despite the fact that individual staff may have difficulty comprehending this and may, inadvertently cause conflict with the resident, whatever problem you might encounter or you may hear about, chances are there's somebody else involved in the care of that person who actually gets it, okay, who's successful. It's just that the communication between shifts and so forth isn't very good, and so in all healthcare settings, so that oftentimes it's simply a matter of figuring out what is working and replicating that. Now, in the situation described, like with wandering, I might just point out that wandering, or whatever you want to call that, is basically normal. Okay, I wander all the time. Okay, and but it's we're talking about here resisting care, wandering, agitation, and so forth. Somebody is making a judgment about what somebody else's intentions are. Okay, yep. And those judgments are often incorrect. Most often are incorrect. But also, my job isn't to judge people. My job is to love and care for people. And the judging stuff just gets in the way. And I venture to say that most human beings don't like to be judged, especially without their knowledge or consent. So, and it becomes, unfortunately, self-fulfilling. So let's take the wandering example. Okay, supposing wandering means going into a place you're not supposed to, like somebody else's room. Well, why would somebody do that? I ask this question of nurses and doctors, including and especially in hospitals all the time. I say, well, have you ever gone in the wrong patient's room? Of course. Well, what medicine did you get prescribed for that? Why did you go in the wrong patient's room? Well, because the rooms all look alike. Okay. Did you ever actually talk to the wrong person? Yes. Well, why did you do that? Well, because the patients look alike. I'm just pointing out the absurdity of this. But put yourself in the shoes of somebody living with dementia in a healthcare setting where they're not quite sure where they are. They don't quite comprehend the environment. But wherever they are, let's assume, for the sake of argument, they consider that to be their home. Okay. They're not thinking to themselves, well, in my home, I'm only allowed to go in certain rooms. It's all their home. Moreover, let's say somebody leaves their room and tries to find their way back. Well, how are they going to know it's their room? Especially if all the rooms look alike, especially if there's no obvious visual stimulus, a picture of them or something like that, to something familiar that would attract them. Okay, this is the very reason why people do things like walk through a door that's that they're not supposed to, because there's a big red sign that says exit. Okay, right. Or even pulling a fire alarm where in big words it says pull, but in small words it says in case of emergency. Right. And so people are just responding to a stimulus in their environment. They're trying to find their way. They're trying to be helpful, okay, be successful. And so, we're talking about physical environments that were not made for people who might be confused, that expect way too much of the people that inhabit them or that work in them, okay? And there's no reason why we couldn't make it very easy for every resident, for every patient, for every doctor, and for every nurse to easily be able to identify whose room is whose, and who and which and what person, who's whom, and what their role is. Okay, and you see that sometimes in hospitals where they use these, in nursing homes too, where they're using bigger badges with bigger letters that identify that someone's a nurse, for example. And some spaces that were designed specifically for people living with dementia often provide visual cues to help people find their room, stuff like that. Okay.
Yeah.
But so, I mean, but the idea that you should be medicated because you walked into the wrong room is absurd. What often happens though, and this is what tends to make these situations worse, is if people do something that is, what we're really talking about is what is socially unacceptable in a specific environment. If people make a mistake unbeknownst to them and do something that's socially unacceptable in a particular environment, the reaction that people get is to be told that they're wrong. Okay. Now, if you've ever done this, if you've ever been in some public space and walked into a room or something, or walked through a door that you weren't supposed to, not only would you be told you were wrong, but you might also be made to feel shame. Okay. Not very helpful. But if you think you're in your own house and somebody says you can't be in your living room, that's going to be completely incomprehensible. And so being told you're wrong in that situation isn't going to right the situation. It's not going to change your behavior in a positive way. It's just going to cause things to escalate. So this concept of telling people they're wrong, in medical parlance, we would call that reorientation. Okay. It usually doesn't work. What we want to do instead is help sort of steer people. Mr. Jones, it's good to see you. I'm Dr. Evans. Hey, how are you doing? Can I help you in some way? Do you need something? Hey, would you mind? You want to take a walk with me? I'd really love to talk with you. What I just described, which is sort of steering people in another way, making them, not threatening them or making them feel like they've done anything wrong, but making them feel like I'm somebody that wants to be with them. That's what I just described is a process which would technically we might call that redirecting them, or it's like steering. But the term redirection is often misused to mean reorienting. Okay, so as a consequence, I tend not to use that phrase because I only point it out just to let you know what it's supposed to mean. But redirecting, if you ever see that in a medical chart, it generally means somebody was told no.
Sure. Okay. And I know that I mentioned earlier that you're a big proponent of knowing the person and how that also really impacts the care that you provide and the way that you approach an individual, and even kind of playing out the again, air quoted wandering examples. Sometimes people walk around or wander or are looking for something, and something about their history may give you clues about what it is they might even be doing or looking for, even beyond just it's their home, and they're used to going wherever they want. We've heard lots of examples of people who like a policeman who used to walk a beat, and so it was his thing to that was what he did for 40 years of his life, and so he's out walking around. Or they might be looking for something, looking for a kitchen or food or something.
Absolutely.
So knowing the person and their cues might also be helpful.
Yeah, that's another great point. I mean, we're talking about human beings being purposeful and wanting to have purpose in their lives. And the notion that somebody who's moving around in an apparently aimless manner or purposeless manner is wandering is usually a grave misunderstanding of what's going on. Almost always the person is acting with intention. It's just they're not using words necessarily to explain what they're after unless we ask them or try to figure that out. And very often knowing them as a human being and knowing that their life story can help us figure that out. But and the thing is that living with dementia doesn't cause people to stop being themselves, okay, by and large. It doesn't stop them from trying to do their life's work and live with the same sense of purpose and intentionality. So the more we know what that is, the more we can help them be successful, and the more successful we can feel in turn. And to your point, this is especially common among people. I have a patient now who, I've had many patients who were nurses worked as nurses their whole lives, or work, or other care providers, and they're in a setting where they see people in wheelchairs and so forth, and it to them, they're at work, and they often go about trying to help others around them, which unfortunately can cause them to come into conflict, you know. And so in a situation like that, or this, this policeman example that you gave, you know, rather than leaving them to their own devices and creating situations where they may come into conflict with somebody else, why don't we, you know, acknowledge that purpose and help them achieve it by encouraging them to make rounds, having somebody go with them, you know, and saying, okay, we've you know, we've done our rounds for the night. Let's do this other thing instead. You know, in addition to that, knowing that they have that purpose, you've just created a solution to essentially any conflict. If something else is going on, hey, it's time to make rounds. Would you come with me? Let's go check on all the doors or something like that. You've created a solution to other problems by distracting that person from whatever was going on and giving them a purpose, something that they can be successful at. So, and then this distraction is another very important and useful, I hate to say tactic, but, you know, method for you basically stopping whatever's going on and starting something else with, you know, a fresh start. So, but in addition to that, when you retire, there are probably going to be things that you are going to look forward to that you like to do in your life. Okay, maybe bingo is one of them, maybe not, but certain things that are familiar to you, that are a source of comfort, that give you a sense of accomplishment, those are the things that you're going to want to do. And so the more people, I mean, if you need help doing that, the more people know you and know what your interests are, know who you are, the more likely you are to get what you want, and the more likely you are to be happy and fulfilled. And so, and you would expect that if you move to a retirement community or something like that, or if you were considering moving to a place and you don't have dementia, you're just thinking, I want to be where I can, you know, be my best self. You would be looking for those things in order to help you make your choice about where you want to live. And so those are things that are not only essential but expected in a nursing home. You know, it's expected that there will be activities that are individualized to your needs, interests, and abilities.
So we've talked about a lot of, you know, I think interesting topics today and approaches for caring for someone with dementia, and, you know, certainly including thinking about the way you approach that person and the way you're providing care to them. The fact that often the different behaviors and reactions to things that the way that they may respond to you is a form of communication, and that you really need to be paying attention to what that is, and also how important knowing the person is in terms of your approach and in terms of, again, what they're trying to communicate, what they're trying to get across to you, and again, how you approach them and provide care that can help reduce any sort of conflict or behaviors that, you know, again, people think may think are problematic, but are just something that the person is trying to tell you that either they need or they want to be doing. And you can think about better ways to approach that. Other things that you may want to, you know, tell our listeners for today, Dr. Evans?
Well, I as you were talking, I thought of another example that to me sort of illustrates a kind of it's a fairly simple way of for people to comprehend sometimes this clash of cultures, but also what a big difference a very small change can make, even in just the words that we use. For example, one of the most frequently used terms that I see either in medical records or in, you know, discussing and talking with, you know, healthcare professionals is this phrase agitation. This person is agitated. Now, people that aren't in healthcare almost never use that word. It's kind of pejorative and so forth. But it has this sort of medical sort of aura to it. So that if I were to call somebody's daughter and say, oh, your mother's agitated. Oh, that sounds bad. Well, what should we do? Well, I've got this medicine that we could try and so forth. Well, is any side effect? Well, it could cause death, but, you know, this is serious. This is agitation, you know. If on the other hand, I said, because again, agitation is a subjective judgment that one person makes about another in terms of what they're doing and what their intention is. If instead I said, your mom is visibly upset, that would create a totally different set of expectations and a totally different conversation. My mom's upset. What is she upset about? Well, I don't know, but I'd like to give her a medicine anyway. It doesn't matter what she's upset about. Okay, she needs to conform to the environment. Okay, and so again, I'm in my own little crusade. I'm trying to purge some of these words where the word gets in the way of what's going on, or what the meaning is. And so if you've ever heard the term agitation, or if you ever hear it again, just substitute in your mind visibly upset. And if I say that to a caregiver, well, she's visibly upset. What could she be upset about? Then we can start problem solving. Oh, what might be going on that could cause that? And again, the other thing that I would just mention to everybody that's participating is that, people who choose to care for other human beings, for their life's work, it's part of who they are. They want to do a good job. Okay, they're generally doing what they've been taught to do, and they often feel a tremendous amount of frustration, pressure, conflict between what they want to do and what they're able to do. Okay, and one of the most gratifying things is seeing, caregivers being able to view these sort of things without this sort of distorted medical lens, and just thinking about human beings and what they're trying to say. And it can be very empowering, instead of being frustrating when they feel like what's needed is a medication and I won't give it. Okay. So, and if you're a family member or ombudsman, and you're probably the expert on this person whom you care about, and what you know about that person, what you can share with others, or just being a guide through some of this problem solving, can really make a difference, not only for the person that you love, but for the other people who are trying to take care of them and really want to do a good job. Nobody goes to work wanting to do a bad job. We all want to be successful, but we don't always have the tools at our disposal. And in addition to that, what human beings most need, generally speaking, is presence, is relationships with other people. It's not so much the words that we say, or the tasks that we do. It's being there, And so, but for people who work in healthcare settings, they often feel like they don't have that permission. And one of the things you can do is to not only you can give them permission by thanking them for doing that. If you keep catching people in the act of doing things the right way, and so I just want to finish where I started, which is to thank each of you and all of you for being the person that you are, and never underestimate the difference that you make in the world. I appreciate that.
Well, thank you. Thanks so much for some great words of wisdom and tips today, both for caregivers and for family members as they think about how to best provide care for their loved one, for the person that they're caring for, in a manner that I think respects the person and is done with kindness and care and love and compassion, as you so often talk about, and also in a way to think about really keeping centered around what it is that the person needs and what they're trying to tell you, and to try to best meet those needs. So I think it's been a very, lots of great tips that you've been able to provide today. I will just tell our listeners that they can get a lot more information about some of the things that we talked today about on the Consumer Voices website at www.theconsumervoice.org, particularly related to looking at good care without the use of drugs for individuals with dementia. We have our campaign that we're partnering with AARP Foundation around this issue, and we have a lot of great resources on our website about that. So Dr. Evans, I'd like to thank you for spending the time with us today and for imparting your great words of wisdom, and we'll look forward to talking to you again soon.
Thank you, and thank you all for letting me share the journey with you. Appreciate it.
Thanks so much.
Okay, bye-bye.